but it is not without risks. So for instance, benzodiazepines is usually the treatment of choice, but it's known to have a rapid, and because it's known to work quickly on anxiety. Things may be changing quickly, so.
What do you know about like with that and SSRIs and like Lexapro?
The benzodiazepine, what would be a brand name?
I'm thinking Klonopin, but I don't know the brand name for it. I'm thinking, yeah. So I have a patient who's on Klonopin. So the risks are that, say, benzos, they're known to cause cognitive impairments. As you know from your reading in older adults, they may reduce your psychomotor functioning. You may be slower, clumsier, you may fall in your house. Other just kind of complications are that, say, older adults may not take their medications on time, or they may just, take things into their own hands and adjust their own medications. My older client says, this pill is too strong for me. I'm just going to chop it into half and take half of it. Or I'm just going to up my own dosage because I need more today. Because of poor patient education, and these may result in adverse events. So older adults on psychiatric meds really need close monitoring, which typically they're not getting and where they're getting help. So onto psychotherapy for late life anxiety. Cognitive behavioral therapy has been shown to be effective in treating late life anxiety, but it's not really any better than all the other active treatment. But there's also very limited research on this, so we don't really know what is the best treatment for it. We just know some form of active psychotherapy is better than none. And most of the outcome studies were performed on generalized anxiety disorder, so there's really limited research on all the other types of anxiety disorders. Okay. So just to give you a brief flavor of what cognitive behavioral therapy, or CBT, is, it's just usually consists of kind of educating your patients about what anxiety is. For instance, I would tell my older patient who has PTSD, who has rarely heard of PTSD, kind of normalizing this is, the flashbacks, the nightmares that you're getting is really common among people who have had a really traumatic event. So things like that, symptoms, triggers, teaching them to monitor their own symptoms, kind of what tends to trigger your anxiety, what gives you a panic attack. Relaxation training may consist of teaching patients how to relax different muscle groups so that they can do it on their own when they're feeling tense and having muscle tension. Cognitive restructuring can involve teaching patients to challenge thoughts about the likelihood of negative events and catastrophic consequences. So my GAD client likes to think that the likelihood of her going bankrupt in the next year is really, really, really high. So I would kind of really ask her, what is the true likelihood of this going to happen to you, given that you have, a stable job, you have a supportive family? What are the odds of that happening? And giving them a more realistic sense of what's going on. And then problem-solving therapy involves, after choosing a problem area, what I learned from Margie, the STAR strategy is stop right there instead of, spinning yourself off of your head. Think of all the possible alternatives that you can pursue in this situation. And then for each of these alternatives, what are the likely consequences? And respond with the best choice. This is the problem-solving therapy has been used effectively with depression in older adults, and it's been shown that it's relatively easy to train kind of just people in the community health settings to administer this to patients. It doesn't take, a PhD-level clinician or a master's-level clinician, so that it's good for integrating this into kind of more community-based settings for treatment of late-life psychopathology in general. So adaptations for treatment, adapting psychotherapy for treating older adults. I will leave this to Bob teaching you about this next week. He has a whole model on how to adapt psychotherapy so that it's appropriate for treating older adults. But just some quick examples, quick and dirty. So if you're dealing with older adults who typically present with some form of cognitive decline or impairment, you may just think about simplifying your homework assignments. So instead of giving an elaborate log for my client to track, at each hour how she's feeling, how depressed she is, or how anxious she is, I just give her maybe like a simple form and say, now why don't we just focus on 1 or 2 stressful events this week and really dissect that event in your homework. Use visual aids to help explain concept, draw pictures, and I'll show you an example. Give brief treatment summaries once in a while. Give handouts on major concepts. For instance, when I was teaching diaphragmatic breathing to an older adult with anxiety and breathing problems, I gave her a handout with cartoons on it so that she can just look at it and kind of learn how to do that breathing exercise. In terms of conducting systematic desensitization, I don't know how many people are familiar with this. So this is kind of a technique used for treating phobia. So for instance, I'm really scared of snakes. And that whole idea is kind of gradually exposing you to stimuli that are related to the thing that you're the most scared of and constructing a hierarchy. So say I'm really scared of snakes, and so the hierarchy at the bottom may involve thinking about snakes. And as I move up the hierarchy, it may involve me looking at snakes at the higher end of the hierarchy, and now my heart rate is really going, and I can feel it. It's me sticking my hand into like a cage and touching the snake. I'm freaked out now. So kind of like that. So kind of, if you're doing this with an older adult, you really want to slow down and not, go to level 8 on your first session, and really go slowly and not overwhelm them. So this is an example of the homework that I do with my client. It's also it also really nicely illustrates the concept of cognitive behavioral therapy as kind of that everything there's a trigger for the symptoms that you're feeling. For instance, my older client says that I have like a new onset of my hip pain or arthritis pain. And I really don't want to leave my house, and I've been just trapping myself in the house for days. That's kind of, we call that an antecedent. And then like an A. And then the B step of this is when she stays home for like 2 weeks and doesn't leave the house, doesn't put on, her fancy jewelry, and she likes to call herself flamboyant because she looks like a peacock when she steps out. But when she stops doing that for 2 weeks, she starts to feel crappy. And so I ask her, so after staying at home for 2 weeks, how do you feel? And she's like, I feel like I'm sick, or that I'm really weak because I haven't been able to leave the house. I'm powerless. My son doesn't call me, and she's obviously not calling her either. So she starts generating all these statements that she can start generalizing to her as a person. She starts believing that she's sick and old and weak and powerless. And the consequences at the emotional level is that she starts feeling depressed and lonely and bored and crappy. And the crappier she feels, the more likely she's just going to not leave the house. And so this is kind of the ABC cycle of cognitive behavioral therapy. And we teach that to older clients. And so as homework, I would have her, pick an antecedent, and can you track your thought processes and your emotional reactions like this. And just pick maybe 2 things and write about as homework. And then just lastly, some future directions for research or for clinical interactions. We should definitely think about, in the papers that you read and the book chapter that you read in discussing outcome research for anxiety disorders, they're using pretty homogeneous samples. These are older adults who are being treated at university academic medical centers. Think about this. How often is an anxious older adult going to go to, say, UCLA for treatment versus going to their primary care physician? So the findings may have limited validity. In these studies, there are also really high rates of attrition, so oftentimes the analyses were conducted just on people who have managed to complete the whole course of treatment, which means that they may like the treatment enough to stay for the whole course, and so this will inflate the effect sizes beyond what they truly are. Again, this we just touched on. And so future research may really need to look at psychotherapy for different types of anxiety disorders, because they're mostly done on GADs. When we think about looking at treatment for anxiety and other psychopathology in places where older adults tend to seek help, such as primary care clinics. And there are really rich avenues of research for populations that present with comorbid medical illnesses, given the high prevalence of medical conditions in older adults, or say older adults with cognitive impairments. If they have impaired executive functioning, what can you do when you treat them? Do you think, say, an